always sort of catch this live. So just going to go straight onto Facebook, make sure our Facebook audiences are sort of picking this up as well, which they are. And one more little button to press. I don't know if you guys have done Zooms, but I think I should be a pro by this now. I think we've done so many Zooms now.
Thanks for hosting this again, Ross. I mean, you are a pro, to be honest.
I don't know about that, but
I don't know how many you've done, honestly.
Yeah, I've lost count how many we've done, but yeah, here we are. Great. So I'm going to share my presentation now with you guys as well. Right. Thumbs up if you can see the presentation, and let's put it in presentation mode. Brilliant. We can getting a few thumbs up, which is always good. Brilliant. So welcome, guys, to our Monday, 1st of March, 2021, Biceps Injuries, Tennis Elbow and Golfer's Elbow. I am joined by probably one of the most sort of referred to shoulder specialist, elbow specialist, and more importantly, a really, really good friend of ours at the clinic. So Mr. Sekis, please introduce yourself to sort of all the people that are watching on Facebook and on Zoom.
Good evening, everybody. I'm Dimitros Tsekes. I'm a shoulder and elbow consultant. My NHS practice is in Basildon Hospital, and privately I work in central and North London and Essex. I work in very close with Rus and other healthcare professionals and orthopedic colleagues to provide a holistic approach to our patients through total orthopedics and R&D Physio Therapy. And thanks, Rus, for hosting this event again.
No, it's the least I could do. It's something that I'm very, very passionate about. It's just making sure people are pain-free, injury-free, and just living a great, great sort of life, especially with the way things have been last year. I want this year to be where people enjoy movement and really just enjoy life, because if anything, last year's taught us is just how crazy it can get. So I'm a shoulder specialist. I basically see predominantly shoulders, but I'll see everything and anything. I'm based in London, based in North London, and have a team of around 10 fantastic other physios that we sort of work with. Let's dive in straight into the presentation. So biceps injuries. Now, a lot of these basically happen, today we're going to be focusing on sort of the lower part of the biceps in particular, or the distal tendon as we call it. So why do they happen? And I'll basically, the way I sort of summarize it is, well, if you basically try to do this, and everyone do this while you're standing with me, while you're listening to me, if you flex your arm or if you bend it ever so slightly and put excessive tension on a flexed forearm, so if you cock your wrist back, and now what I want you to do is push really hard against with the other hand, you find that you start activating sort of that sort of tendon area, you start feeling your biceps working. And sometimes what happens is when you have an excessive force, either it was too much, it was too fast, it was too soon, which is every gym goer that comes, April 12th. And straight away you start sort of feeling that sort of biceps injury kick in, and you feel it very, very sharp, painful. It can happen on sharp twisting movements. It can happen on weights. And like I said, the speed of movement is very, very important. So what do we do? So as healthcare professionals, a couple of things I know that we've got some healthcare professionals or some physios watching this. So, I always think of it as a simple way to kind of assess a biceps injury is, does it look okay? Does it look swollen? Does it have any redness around the area? Is there sort of palpable problems, or can I feel that person? Can I ask that person to sort of touch around, and is it sore, and specifically in that sort of biceps groove area? And then, are they getting a dull pain? So prior to actually tearing their biceps or having a proper biceps rupture, most patients will actually complain of like a bit of a dull belly pain. So in that muscle, in that biceps area, they'll just feel like there's been a dull pain. They might have tweaked it a couple of weeks ago, and then all of a sudden they went to do a simple movement like picking a weight in the gym, lifting something up really quickly, and it goes like that. So you get that sort of quite classic story, as I like to call it. And then, the problem is that we don't necessarily manage these very well. And my instinct and my reaction is, let's get them seen to with an urgent referral, especially if I'm suspecting like there's a half tear or there's a complete tear, and let's get some imaging on it as well. So whether you have access to ultrasound imaging like we do in their clinics, or you can refer out to the GP who can forward on. The problem becomes obviously times like COVID. Now, I know, Dimitris, you've been struggling to get, even if people have tears or partial tears, with COVID, everything has stopped. Like, how have you guys sort of seen bicep injuries and how you manage bicep injuries?
So nowadays, the main problem lies into our NHS practice, where the patients sometimes take a few weeks to be referred from their GP, or it takes a while from them to be seen in our fracture clinics. So I'll be honest with you, over the last 6 months, we have been doing basically delayed repairs of biceps tendons rather than acute repairs of biceps tendons. Of course, you need to select your patients as soon as you see a patient. So the patient can be either in the younger population cohort where they had an acute injury, they are a builder, a manual worker, or an athlete. These patients tend to seek advice quite sooner. And there are the other patients where they're around their 50s or 60s who have sustained an injury, and they go through the conventional way of going through their GP, get referred, etc. You need to approach individually these patients and ascertain that they actually need to have something done about it. When we're talking about a complete tear of the tendon, you need to explain to the patients that they will lose some force in their arm. So if you are a builder, for example, and you lose supination power, you'll have problems screwing or doing hard manual work for the rest of your life. So it's maybe you have to repair it basically. If you are in the more elderly population cohort, you need to see the hobbies, the demands of the patient life, if they want to ride motorbikes or bicycles, and you have to commonly agree to proceed with surgery or not. If they think that they can manage throughout their life with just non-operative management, then of course I'm sending you to Euros, and then you manage their expectations. You try to make their elbows as fit and strong as possible, and they get on with their lives absolutely fine, without, I cannot hear you, Ross.
There we are. Sorry. So that's the fantastic thing about the biceps, is that you can manage, or the elbow, you can manage very well. And I think a lot of people struggle to understand that, is that although you've torn the muscle and it might look very much like, we call it the Popeye sign, you can manage very well without necessarily getting it surgically sorted. I know we're going to talk about the surgery, and we're going to talk about what it looks like post-surgery and stuff, and we've got some fantastic videos to show you guys. But if you manage them appropriately with gradual load rehab, setting expectations, and most importantly, treating the person in front of us, you said it rightly, if you've got a manual job, you will need to get that sort of fixed and looked at. And the problem over here is that as physios, we struggle to sometimes make that urgent referral happen sooner. And even if we do, we sometimes don't know how to sort of connect to surgeons like yourself to get that surgical intervention. And we're going to talk about how soon do you need to do it? Like how, there's a time frame, and I know you and I sort of greatly sort of discuss this time frame of how quickly should someone get surgery. Let's go on to the next slide. So what is physio, and how is it going to be any benefit to someone if, for example, they're going to need surgery in the first place? So while they're waiting for surgery, there is no reason why we still can't do stuff like managing that sort of initial injury, getting that sort of inflammation down, but just by getting them to sort of, get some ice on it, getting them rehabbing it, getting them to still train their rotator cuff. So the great thing about the biceps and the area is that you can still do quite a bit of movement with the shoulder, which, then leads to my next point, is that because a person's had the biceps injury, that doesn't mean that we should stop them doing exercise. They should still stay fit, they should still stay active, they should still get moving. And I love doing a bit of manual therapy, giving a bit of pain relief, but I wouldn't sort of dig my finger in there trying to basically massage the tendon, because we all know that massaging tendons doesn't really work. So this is obviously something that we are going to sort of touch base on. But when you see someone with an injury, what's the first thing you do, Dimitris?
So apart from taking a history on whether there's an acute injury in place and clinically examining the patient to verify the injury, the next step is to be also legally protected and to explain to the patient the extent of the injury, is to do either an ultrasound scan or an MRI scan. Now, the ultrasound scan, I'll be honest with you, it's more easily accessible, and it can dynamically assess the tendon. okay, and they can give you an estimate of whether the tendon is close to its attachment, where the radial tuberosity, or whether it has retracted. On the other hand, if you do an MRI scan, you can actually show the patient, like in this case, where this was a 6-week-old biceps tear, that it has really retracted from the point of recession to at least 10 centimeters. And in that way, you can quantify the injury, and then you can give the patient also, an insight on what you are planning to do and where this tendon should lie. And you can do your preoperative planning also based on this. For example, if with this kind of extensive injury, which is more than 6 weeks old, most likely you will have to do two small incisions in the anterior aspect of your arm. Whereas if it's very slightly displaced, then you can do just a single incision around the area of the forearm. So it's for preoperative planning and also to give the patient an insight on what to expect from the operation.
Yeah. And would you go straight for an MRI scan, or if there was initial injury, like, obviously with the swelling and everything around there, would you get a better picture with an ultrasound scan or an MRI scan? What's your
ultrasound scan is better, to be honest with you, with a radiologist that you actually trust, who can give you the extent of the injury, whether whether the lacertus fibrosus, for example, is intact or not. You can also dynamically test the tendon, and he can tell you, for example, that if there is a partial tear, but actually the patient can exert force, supination force, or just a long head, or the short head is detached, But you need to trust your musculoskeletal radiologist, by heart, to be honest with you, in these cases.
So just to kind of clarify that for the guys who are not sort of non-medical, essentially what Dimitris is basically saying is, you need a good indication. And one of the things is obviously understanding whether it's a partial tear or full tear. And management can change for both things. Again, some people would say, well, partial tear, can we just carry on rehabbing? And yes, you can. But then you can go the other way as well and say, actually, for a partial tear, you may want to continue and actually still have the surgery. So again, one or two ways. Some people would say for a full tear, we don't need surgery, just leave it the way it is, and that's fine. And then going back, it's a full tear, let's have some surgery. So it all depends on the person in front of us, because that's the most important decision that we're making, is that the person in front of us understands what we're about to do. Yeah. So this is something that you've basically done not too long ago. That's the sort of bicep, and then.
So that's the biceps, and that's the implant I am personally currently using, which is the Alpha Extento button. It's basically an implant which allows this implant gives has a doesn't allow the tendon to tear. You need to have 5 times more force applied to the tendon for it to fail. So if a biceps tendon fails at 100 newtons, this implant fails at 500 newtons. So it's a very strong implant, and it allows you, as you can see, you have to drill a tunnel into the insertion of the tendon or to the radial tuberosity.
Yeah.
The tunnel, as you can see, is bigger proximally because it allows you to drag the tendon into the actual bone. You see, and this is the actual animation of the technique I am using. It's a simple technique, reliable technique with very few potential complications, which works perfectly well in my hand. Other surgeons prefer other techniques, but this is my single incision technique that I'm currently using for the distal biceps tendon tears.
Yeah, so that small little white thing that you guys saw on the X-ray essentially is what Dimitris basically uses to kind of place under,
correct,
turn it, and then sort of obviously use the suturing skills to kind of like make sure it's intact. And if you think about it, 5 times the actual force. So, you've got a very solid structure there. And I think this is where the confidence needs to improve for patients to understand that it's not just going to rip all of a sudden. All right. Now, what I'll do is I'll stop that share and then we'll go back to the sort of presentation. But this is just to give you an idea of the sort of level of technology advancements that have happened as a result of just years and years of sort of, biceps research. And then more than that, just the surgical techniques have improved. So everyone can read this slide, by the way, but it's about sort of biceps repair and how you can lose around 50% of your power in your forearm, and then only 20% or 20% of your elbow strength, elbow flexion strength. But people who don't need hard working lives who don't necessarily need that repair, they can manage. Although it's not going to heal on its own, which is a misconception that most people come to you with. I know there have been a few people that will come your way and they'll say, well, if I just leave it the way it is it going to heal by itself? And the reality is it's not, right? It's just going to stay the way it is.
Or maybe get worse, to be honest with you.
Exactly. And then the next thing is obviously looking at the timing for surgery. So for any of the physios here, I'd love to know what you guys think of your times, or when basically the optimal time for surgery is. But from all the research that I've been reading and stuff, and all the research that I know, and all my patients that sort of come in with these kind of sort of injuries, the first 2 weeks to the first 6 weeks is where I would love for that tendon, this is the person's tendon, to be repaired. What is your optimal time, Dimitris?
Totally agree with you, Ross. The ideal time frame is within the first 2 weeks. If that is the case, most likely you can use a 2 centimeter incision over the forearm, deliver the tendon, and repair it safely. If beyond the 6 weeks period, then most likely you have to do 2 incisions, two centimeter incisions, nothing significant. We will see later on the video from one of my colleagues who confided in me to do his biceps repair, which was around 6 weeks, post-injury, with good outcomes. But the patient needs to understand that there is a higher chance of a higher degree of potential complications from it. And if you extend beyond 6 weeks, there are cases where the retraction is significant, where you might need to use an allograft. Most commonly an Achilles tendon allograft or a palmaris longus allograft. So either an allograft taken from the forearm of the patient, or either an autograft from the forearm of the patient, or an allograft from an Achilles tendon to augment your repair. Why? Because you cannot deliver, it's so scarred up that you cannot deliver the tendon all the way down and fix it. So you need to augment your repair. And that delays the rehabilitation, obviously, and that has more potential chances of complications. What I tend to tell the patients, is that this is a decision that unfortunately they have to make quite soon after they see me, okay? And that if they are happy to accept that they will lose some power in supination, significant power, in supination, and some power in flexion, and that they will have cramping in their arm and forearm for at least 6 to 8 months after the injury. If they're happy to accept that and accommodate with their way of living and profession, fine. If not, the sooner you do it, the better it is. The simpler the outcome, the quicker the recovery.
Absolutely. I think the same thing goes for rehab. So a lot of the guys who I see with their own tendon repair recover so much more faster and so much more better. But again, it all is about sort of that gradual, slow progress. So the job with the surgeon is done, but when it comes to sort of, going into physio, that's a whole nother ball game. And you've got to be really sort of very, very clear when you sort of start this whole journey, because it's not just going to be a surgical connection and then that's it, I'm back to 100% back playing sports and stuff straight away. It's going to take a lot of time. There's going to be lots of hiccups, ups and downs. We may even need to send you back to the surgeon to have it looked at a couple of times, like for reviews, for checkups and things like that. So let's go on to something that obviously you and I are very, very sort of passionate about as well, which is tennis elbows and golfer's elbows. So for those sort of non-medical, again, here it's just lateral epicondylitis, so it's just the outside. Now, I'm not a big fan of sort of, seeing these little cuts on people, because that's not how tendons present themselves. But there's obviously stress caused to the area that causes these injuries. And we've got a lot of tennis players, I know from one of the tennis clubs that's in North London that joined us today. So I'm sure they're watching this slide very intently. So how does it happen? We'll stick to sort of the golfer's elbow in particular. It's a lot of sort of, again, similar gradual or overuse repetitive sort of stuff that happens. So a clear example is going to be March 29th, when all the sports clubs open. I know you and I are going to get literally a flood of people coming in 4 to 5 weeks later with elbow problems, because they've just gone too hard at everything. So, if there's 5 days where they can book people and to play with, as a social sport, they're going to book 5 people on. If they're going to be doing sort of, 5 rounds of golf, they're going to go and play 18 holes, 5 days a week. And the problem here is that it's not that you can't do it. It's just the elbow might just get very, very sore, especially for the golfer's elbow. There's a lot of pain on movement. There's obviously difficulty, things like lifting the kettlebell, kettle, the jars, the opening of the doors. Simple tasks that you and I take for granted can be really, really acutely painful, especially for people who are suffering from golfer's elbow. And there's always some slight restriction. People don't necessarily want to go into full extension or full flexion because it's very, very painful. So some of them will actually complain of pain at night because all of a sudden their arm has moved into an extension position, for example. And one of the things I find is obviously slight reduction in external rotation, but it's not necessarily all the time. Because they're just scared to kind of go into that full extension, going backwards as well into external rotation. What would you suggest? Like, would you suggest any sort of EMG studies when there's tingling and numbness involved, or would you say not necessarily?
So first of all, for golfer's elbow, let me make a comment here that nowadays, over the last year, since patients have been in lockdown and they have started working from their workplace, they have moved their workplace at home, we have been seeing golfers and tennis elbow because they have not adapted properly to their new workplace. Yeah. So we're seeing patients who are struggling with severe elbow symptoms, both from lateral and medial epicondylitis, because their keyboard, for example, is not ideal, because their desk is not ideal. However, with proper physiotherapy and when they adapt their workplace, these things can be, can go past. Yeah. The other thing I would stress is that when we're talking about golfer's elbow, you want to make sure that it's not a complex golfer's elbow. In other words, where a compression of the ulnar nerve, which is next to it, is also involved in the pathology. And you need to ascertain that the patient has specific function. There are specific provocative tests, which I don't want to go into too much detail now, whether the ulnar nerve is giving power to the intrinsic muscles of the hand, whether it's giving cessation of the inner aspect of the hand, for example. And if that is the case and you suspect that, then you send the patient for nerve conduction studies. And then depending on the outcome, for example, you see a video later on of one of my patients that unfortunately he had both tennis and golfers and ulnar nerve, compression. You have to deal with them at the same time since you're utilizing the same incision, of course. But yes, you need to make sure when you're examining the patient about golfer's elbow, never forget about looking after potential ulnar nerve compression clinically. And if that's the case, you send them for nerve conduction studies.
Yeah, so this is anyone who's having that sort of that tingling, shooting pain, the sort of burning sensation around sort of the inner elbow, getting that sort of tingling in the last two fingers. And most people will do this where they basically go and get like a massage gun and they'll sort of just ram around there and sort of, keep poking it, keep sort of pressing it, wear straps. And I know we're going to come on to that later on, but all of these are passive things that will only give you a short-term relief or may not even make a change or may make things worse. So the problem here is also where you need to kind of be very, very almost listening to your body and just saying to yourself, actually, you know what, that might have just been one game too much. I need to kind of go back and, head over and do some strength work exercises, reduce the amount of time I'm playing, and even just making sure I'm giving myself adequate nutrition, sleep, hydration, and all these things we take for granted. One of the things that was interesting that you say about desks, one of the, I found that actually it's the time spent being in that against the computer being a problem for these golfers and tennis elbows that have come from repetitive work problems versus actual, the desk space might not really be ideal. They might not have their comfy chair from work. But I find that people are actually working longer hours because
I totally agree, Russ. I totally agree.
You're working longer hours. I'm sure I know that, and I know I am as well. So it's very important to kind of like take regular breaks and get off your chair, or even just put a timer on your laptop to kind of tell you, hey, it's half an hour, it's 45 minutes, it's 1 hour. Let's get a move on. So we'll go on to the next thing, which is how do we help it? So rehab, now people think it's going to be taking, a few sessions of acupuncture, which is going to make it feel better. I have nothing wrong against acupuncture, but I find that looking forward to just sort of passive treatments, that's not going to get you results. Wearing a strap and playing, yes, you might get away with it, but then for how long? And in rehab, don't expect your elbows to sort of bounce back just like that. An injury can take 3 months plus. And when I mean plus, I've had people for 18 months having elbow rehab because they've just not been able to understand that every time they go and provoke it, we're back at the starting line sometimes.
And the reason for that, Ross, again, sorry to interrupt you, is that it's not just a simple inflammation. We need to let the patients understand that it's not just a simple inflammation of a tendon. Unfortunately, in these conditions, especially when they become chronic, when they last more than 6 weeks or 2 months, then the tendon itself changes its substance. It's the fibroblasts, for example, the cells which are producing collagen are becoming swollen. They multiply. There is an influx of vessels into the area, and you get what we call angiofibroblastic hyperplasia. That's the medical term. Basically, the form of the tendon inside changes in a way where a simple rehab or just putting a brace simply will not improve the symptoms. Hence the persistence of the symptoms and the need for further treatments.
Yeah, absolutely. Thank you for sort of going on to that, because it's important to understand that once that structure changes, there's going to be time required and enough stress required on that particular tendon or the area to sort of almost reverse the process, and that can take a while. One of the things we have, our famous, is that our bodies are not Amazon Prime. You can't get next day delivery. So this is the thing with rehab especially. But that's not to say that you can't address a few things. So pain management is another thing. I know people do sort of go straight for the anti-inflammatories. They go straight for cocodamol. They'll get prescribed some stronger painkillers from the GP, and I'm not necessarily against it, but I'm also not necessarily going to say you can just take painkillers. I know there's a lot of golfers out there who take 2 ibuprofens before their round of 18 holes. They'll go and have their lunch at the clubhouse, and then they'll carry on taking another 2 hours, another 2 painkillers, ibuprofen, after playing golf. And this is not the way to kind of like be dealing with the injuries. Shockwave, I'm going to talk about Shockwave in a bit. Biologics, I mean, I know you do PRP injections. Do you want to just let everyone know about what biologics are in particular?
Yeah, I do PRP injections. PRP is platelet-rich plasma injections into and that's actually the only injections that have been scientifically proven to improve the symptoms from tennis or golfer's elbow. Unfortunately, when patients see us, they have already been injected steroids by other professionals. And when you have a steroid injection into your tennis or golfer's elbow, instead of improving, you're actually deteriorating the condition of the tendon. It is going to be proven by many studies of steroids versus just normal saline injection into the tendon versus placebo injections. So people should understand, both physiotherapists, GPs, and patients, that they should avoid steroid injections in the elbow, because the symptoms will come back, and will come back more aggravated, and potentially at some point the condition is going to be reversible. So the only injection that has been proven really through a series of studies to improve the condition is PRP injections. Not to all patients, to about 70% of the patients, and the improvement might take anywhere from 2 weeks to 6 months, with physiotherapy at the same time.
Yeah.
So yes, I do offer this treatment to the patients, but you need to tell them the whole story, what to expect, how long the treatment is going to take, versus obviously just physiotherapy or versus operative treatment.
Yeah, and one of the things we've always been passionate about is saying no to steroids around this area, and particularly blind steroids or any steroids around the area, just because of the sort of the effect they can have on the tendon itself. I know you've treated elbows. They've basically been mismanaged by other health professionals, and these people come to you as a last hope. How does that feel to you? Like, I'll get frustrated. I get super frustrated when I see people having injections around the elbow.
The issue is that when someone has had 3 injections in the elbow, the issue is that as already you most likely, if you do an ultrasound or an MRI scan, you will find partial tears in the tendons, and you'll find calcifications in the tendon. Therefore, they make an already difficult situation almost irreversible. So in that case, again, you need to take a step back and again offer non-operative treatments to the patients, which I always do. You always need to offer the patients all the available treatments. In my practice, I offer them physiotherapy, I offer them PRP injections, I offer them operation. I give them the facts and allow them to decide based on their requirements. For example, if someone wants immediate relief, I can tell them that the golfers or a tennis elbow surgical release will give them relief within 2 to 3 weeks post-operatively. They will already start feeling better. Yeah. But then it's a more invasive method with potential complications.
Absolutely. So we'll go on to Shockwave, and I'll just play this video. So this is one of My patience.
My name's Suzanne. I'm a personal trainer for Athletic Development Club, and I have been suffering with tennis elbow in both of my arms since last April. I heard about Shockwave Therapy through R&D Physio, and I am slowly reducing the pain in my arms. Unfortunately, because I lift weights a lot, it's a slower journey than I would have liked, but it is slowly getting there. I can definitely feel a difference.
Great. So I'm not going to sort of play that because I'm sure we didn't pay her to do this video for us, but she's really benefited. So this is a sort of mid-40s patient. Does a lot of weightlifting, plays a bit of tennis as well, and is a classic presentation. Now I'm very passionate about Shockwave because I do believe it's got a place in elbow rehab. Now just a quick brief sort of overview. This is what the machines look like. This machine here is known as the radial, which most clinics have. And this kind of penetrates around 3 to 4 centimeters at max on different setting. This one is quite painful. So radial is quite painful. It does stimulate the healing process. And again, the way to think about it is that it's a sound wave going in and around the tendon site in the area. One, it can help reduce pain for sure, but two, it's bringing some extra blood flow to the area just to kind of help that sort of healing process. Now we don't use straight away, so we wait at least 4 to 6 weeks. Once things become a bit chronic, that's when we'll start using it. This is my favorite sort of approach. This is only a 2-session or 3-session approach, which is a focused. It's very sort of pinpoint, hence the name focus. And again, seeing really, really good results with this in our London clinic. Now, some people have had Shockwave treatment. I know there's some on this webinar who've had Shockwave, but the problem is they don't necessarily have the rehab after. So you've got to do some high level loading on this. So not just by lifting some resistance bands, initially, yes, it might be working, but I get, 4, 5, 6, 7, 10 kilos being passed through the elbow because that's the amount of load you need to put that. And then the focus is not just by doing one exercise, it's by doing a whole set of exercises to make it specific to the person's sport. So if it's a tennis problem, it needs to be linked back to tennis. It can't just be, here's a piece of band, do these exercises, do some stretches, and that's it. And then, like you said, a holistic view on the injury. So if someone's really sort of, keen to get back into the courts, it helps the mental health. We've all sort of felt it, and we're all excited about sort of returning back to sport. But just go back, just knowing that you don't want to go basically all in straight away and then pick up an injury that's going to wipe your rest of the season out. Surgical management. So I think you've done this, and I think you've already sort of highlighted, but it's where rehab fails. At what stage do you sort of say, you know what, we've had enough of rehab?
Usually the patients know when they had enough, to be honest with you, Rus. When they have had their injections, they have had their physiotherapy, when they have not improved, they say, look, do something for it. So then offer them, the operative treatment. And the operative treatment, again, it's a day-case procedure. You will come in the morning. The procedure itself doesn't take myself more than 15 minutes, 20 minutes. It can be done under local anesthesia or general anesthesia, whatever the patient prefers. In 2 weeks, you take the sutures out. And honestly, at 2 weeks, I see the patients improving already. They're already happy with the outcome. And by 6 weeks, everything is fully healed, with your help, obviously, Russ, in the rehabilitation, and they're back to their normal activities. With regards to golfers and tennis elbow release, I cannot, not based on my studies, on my facts. My facts, I might say whatever I want, but based on the good clinical studies, they have up to 90% success rate. When you know how to properly release a tennis or a golfer's elbow with proper physiotherapy, obviously.
Yeah, and just again, guys, if you're getting golfer's elbow, you're getting tennis elbow, and you're getting lots of pins and needles, please, please, please don't leave it to last minute. The more irritable a nerve is, the more time it's going to take for that nerve to settle down. And one of the things we know that is that, if people don't get that help on time, it can really affect it. So just a bit of a brief anatomy. So, I'm always a big fan, I'm a bit of a geek. So, this is your sort of bony prominence on the inside part of your elbow. And then you can see how close these nerves sort of run around it. Now, there's a reason why you will feel a bit of pain around there and tingling because of that pressure that can go on these nerves. So, Dimitri, you want to talk through this patient of yours?
So this is one of my patients that has been recently discharged from my care. He had an injury back in February 2020, unfortunately, just before the COVID pandemic, stepped in. He had telephone consultations with his GP, then followed up by injections, I'm afraid, both on the medial and lateral epicondyle, was not improving his symptoms. Eventually, he ended up in my clinic somewhere around November with severe both medial and epicondyle and lateral epicondyle pain, with symptoms from his ulnar nerve, with reduced sensation over the inner aspect of his hand, with finger escape sign, as we call it, where he could not close his little finger inside, or where his the little and the ring finger were sitting like this. So, it has the characteristic clinical sense. We proceeded with urgent nerve contraction studies. It showed, on top of everything, compression of the ulnar nerve. We decided to go on and release both the medial and the lateral side with very, very good outcome. This video is now 6 weeks after the operation, and he's already discharged with proper, with full range of movement around his elbow, pain-free.
Yeah. And again, it's important to know that although he's elbow pain-free, he still needs to take his while to build strength up over the period of time. So similar story on the other side of your arm, which is sort of, where a lot of gym goers and guys who are lifting heavy weights in the gym will sort of pick up injuries. I know we've seen a big increase in people doing home workouts, like, rapid burpees, rapid push-ups, people who are doing 100, 200, 300 press-ups just to kind of keep that, because they can't go to the gym and lift heavier weights. So they're using volume training essentially to cause an injury to the area. So any injury, if you break it down, it's too much, too fast, too soon, especially with tendons. So here's a good example. Sorry, guys, whoever's eaten their dinner, this is sort of just what Dimitris has sent me. So
that's a next technique. Basically, the tendon is so angiopathic, so fibrillated, that simply by putting your blade on top of it, the bad tissue comes off. It's a simple way to treat it. You remove the inflamed tissue. Sometimes you need to repair the tendon back to the lateral epicondyle. That said, just to add, Ruth, that lately we have many patients coming from overdoing with DIY at home.
Very interesting.
They're not working, in their workplace. They do loads of DIY. They come with extensive injuries, both in the flexors and the extensors of their elbows. So I would say that that the cohort of patients we see over the last year are not the tennis or the golfer players. They are the DIYs and the worktop, the change of the workplace environment that we're seeing.
Absolutely. I mean, you'd be surprised how many people get frustrated with these injuries. And these were called niggles, right? These are just called niggles because people don't take these seriously unless and until you actually have pain around this area. And anyone who's had this pain will tell you it's frustrating. So again, rehab is very similar. Please, please, please move away from bands. Start lifting weights, because that's the way to improve elbow strength, and that's the way to improve shoulder strength and connecting everything up in that kinetic chain. Sport specific, make it sport specific. If your physiotherapist is not giving you enough drills to kind of link it back to what you want to do, ask, get that progression and make sure you have a clear plan return to play. Because the frustration is that not Dimitris, but there are some surgeons out there who will just say, right, you're pain-free, off you go. And then all they do is just go and play a game and they're back into the surgery again. You need to have a clear, gradual progression. Someone who's had surgery, I'll probably build their strength up over sort of 2 to 3 months before we kind of go and hit some balls and stuff. So, it's not a quick, it's not a get surgery, get pain-free and then back into sport straight away.
I don't know if I'm correct, Ross. I normally tell them that within the first month or 6 weeks, it's all about getting the movement back and make you pain-free again. Beyond that, our physiotherapists are going to build up your strength again. So I try to avoid within the first month, and of course after speaking with you and speaking individually about each patient, I try to avoid too much loading for the first few weeks. You need to allow the operation site to rest. You need to allow the patient to have full movement and then gradually recover, to full strength and better strength usually than what they used to have, to be honest, and pain-free.
Absolutely. So this is just one of Dimitris' colleagues who's actually performed this, or Mr. Tatani has performed this, but I know Dimitris does a better job, but we're not going to tell this. So this is a biceps repair done with a graft. Now, this patient waited a very long time to do this operation, primarily because he just wasn't happy with it. He didn't like the way it looked. A good way to explain this is that he actually felt less of a man, essentially, because he didn't have his bicep. And, this is a psychological impact he had on it. He actually cried after he did his push-ups, because for him, this was a mental block. For him, his strength was in his masculinity. And this is a carpenter, did it very awkwardly at work by lifting a metal heavy staircase. Really affected his mental health. Part of our role as physios is not necessarily injury management or any of that. It's reassurance. It's making sure that there's an outcome. So the second is basically around 13 to 14 weeks after surgery. Again, I made sure he's strong enough to do that. And then this is just last Tuesday when I saw him, and he's got very, very good movement. He's got, he started lifting 7.5 kilos on one side and lifting it to get his bicep pump going. And, probably the happiest I've ever seen him since I first met him. So let's talk about the psychological impact. What happens when you start doing these releases and these surgeries and stuff? Like, how does the patient in front of you then feel?
To be honest with you, first of all, they are very grateful. So after the operation, I mean, to us, it's a simple procedure. We do it on a weekly, so to say, basis. The patients come back with gratitude on what you have done to them, and you think, oh, hold on, I just repaired the tendon. It's not like I did a heart surgery on you, but still, because especially if that's their dominant hand, and nowadays, stress plays an important part in our way of living, and having your arms functional, being able to perform your hobbies, being able to go to the gym, being able to unstress yourself, go out in the wild, drive your motorbike, all these things, they feel grateful about it, and they are ready to undertake big operations like the one that my friend Rupen did. As you can see, he has done a lazy S incision over the anterior aspect of the elbow. This is because Rupen, I know he doesn't do such a long incision, but because this was left for a long time and he had to use a allograph, he had to do extensive releases, mobilize the tendon, apply extra bits of tendon on top of it to secure it, nicely. On the next video you will see, which is the video of one of my colleagues, anesthesiologist. He had a much simpler repair, 4 weeks down the line, 2 small incisions. You can barely see any incision around there, to be honest with you, on his elbow. And he achieved within 6 weeks full movement with full strength back. So again, we need to stress that in this kind of injuries, tendon injuries, the more you leave it, the more tricky it is for the surgeon to deliver the optimum outcome to yourself. And the bigger the chance of complication and the longer the recovery. But it's one of the procedures that have very good outcomes and gives pleasure both to ourselves and to the patients.
Absolutely. So this just brings on to obviously return to sport, and I thought I'd put there. Physios are definitely going to be busy. I've already pre-booked people in. I found every person I know who's got that sort of tendency to go, 0 to 100. I'm booking you an appointment 6 weeks down the line once things open up. Surgeons are going to be busier because they're going to be inundated with problems. Now, whoever's watching this, please, can you not see me and can you not see Dimitris in the nicest way possible? We want you guys to be educated, empowered to make the right choice, but more than that, gradual build up. So, start with 2 games in a week, maybe 3, but don't necessarily go back to back and start sort of hitting 100, 200 balls in half an hour. When's the last time you went on a golf course? Unless you play golf as shockingly as I do, that's the only time you're going to be hitting 200 balls in a round of golf. And then the same thing, obviously, going just with tennis. But yeah, forget just golf and tennis. Just generally take your time, build it up, build the strength. If you don't know, ask. There's lots of free resources out there. And then sort of, make sure you're not necessarily injuring yourself. Any other advice for anyone who's sort of, with the obviously all the clubs and everything opening up, gyms opening up? Dimitris, any advice for everyone?
I mean, like you say, all these injuries are happening from repetitive, excessive, eccentric injuries over the tendons. Both the biceps injury usually happen when you have an eccentric force, sudden force. On the golfers and tennis elbow is those repetitive movements that we do, either going back to the sports club or overdoing DIY. It's a matter of technique mostly, to be honest with you, and not knowing our body well. And unfortunately, when you are eager to go back to playing your favorite sport, you don't think about your body, you think about the pleasure you're getting from it. So guys, take it easy, warm yourself up before starting to play, stretch yourselves before and after your play, as simple as that. And as soon as you feel a sudden pain or or a neck in your elbow, slow down or stop.
Yeah.
Come back after a week or so.
Absolutely, and just build it up gradually again. So obviously don't slow down to rest. One of the things that people do is put on a brace and they just say, I'm resting for a couple of weeks and then go back. That's not going to change anything. It's all about strengthening it up, reloading it, and it's okay to have some pain while you're doing some exercise as well. I'd love to take on questions. So this is the time, use your chat box to sort of leave us any questions, any specific questions. We're happy to take that on. I'll open that up and we will send these slides out to you guys, and for anyone who wants a CPD certificate, we're going to definitely sort of send this across. But yeah, unless we've answered all the questions, just seeing on Facebook, I think we have 1 or 2 questions come up on Facebook. I'll just double check. Brilliant. Yeah, so great, thank you, Emma. That's lovely feedback. Normally normally you join webinars and you never get feedback. So this is great. Thank you. I know. So Dimitri, so you can't read this, but it basically says you can clearly see how passionate you both are about this enjoyable webinar and very informative, which is always good. And I think that is good. We've got one question. What's the best way for people to basically connect with you, Dimitris? What's the way that people can find you?
So they can find us through our website, which is www.totalorthopaedics.london, and also the websites of the hospitals that I work for, at the Hospital of St. John St. Elizabeth, at BMI Hospitals, Spar Hartswood Hospital, and Highgate Hospital. Through the websites, they can find all my details.
Fantastic, fantastic. I've got a question. I know it's referred to me privately, but I'll share it because so can you expect to be pain-free just by doing physio alone? It would be a very difficult one to sort of understand, but if it happened 2 to 3 years ago and you're just doing pain management with acupuncture and you just keep resting it, I feel like there needs to be more around this area. I think strength training is probably ideal. I'd love to help you out. So one of the things I've forgotten to mention is anyone who's watching, who's a patient or would like to come and see us for physio, we know times are tough, so we're happy to have your first 2 sessions covered at half price. So that's 50% off basically for your first 2 sessions. Just email me directly after this. And then another question, can you please tell us the 2 diagnostics for tennis and golfer's elbow? Look, again, everyone's got a different way of assessing. I think for me personally, the biggest assessment is the history taking, asking someone the right questions. But if it's a physical assessment, I would do a lot of resisted testing and understanding where the pain was and palpation. What would you do differently? Anything differently there for diagnostic tests?
As you say, history is about 70% of the diagnosis or 80% of the diagnosis. Then falling to clinical examination, you need to look, feel, move. So you start by moving, allowing them to move their elbows. So then the point where their pain is, you feel normally either the lateral epicondyle for tennis elbow or the medial epicondyle for golfer's elbow for pain. And then you do the provocative test. For example, for tennis elbow, extension of the wrist under resistance provokes pain on the elbow. Extension of the middle finger under resistance provokes pain on the elbow. Same thing with golfer's elbow. Flexion of wrist under resistance provokes pain over the medial side of the elbow. Simple test where they are quite characteristic tests, provocative tests for golfer's elbow. But then again, you need to see. We always say in medicine, always examining the joint above and the joint below. So it's a more holistic kind of, or speak about their diet, like you say, see what they have done from a physio point of view. What are their requirements? But these are the main, let's say, provocative tests, that are going to be asked in an exam.
Yeah, we have a question about the PRP. Is it your own plasma that's used, or is it donor plasma? So
it's your own plasma. So what happens is that you have, ideally, I take the patients to theaters where everything is completely sterile. It's a sterile environment. So you take about 30 ml, so a big syringe of blood from the other arm. And out of these 30 mLs, you actually take a concentrate of 3 mLs, which is the platelet-rich concentration of plasma. And then you inject it around the area of the tennis or the golfer's elbow, and that allows for, vast healing potential. So yes, not donor, it's from your own blood. It takes around 15 minutes to half an hour, depending on the system you're using. And as we discussed, it has 70% chances of improving your symptoms, anywhere between 2 weeks to 6 months. Again, that depends on the patient, depends on the type of the injury he had, depends on the quality of the rehabilitation.
Absolutely. And the last question is just, can you get both? So I think, I know tennis elbow, golfer's elbow, is it always on the inside or the outside? I think we've showed that this picture kind of shows where each one is. But one of the things I have had is basically both patients come in with both injuries at the same time from one sport. It doesn't need to be tennis or golfer, so we'll move away from that term. It's just
these are, to be honest with you, terms. You know, you can see golfers with tennis elbow, or tennis players with golfer's elbow, or patients who, when you tell them you have tennis elbow, they say, I don't know what tennis is. You know, but these are just terms because it was more often seen in tennis players or in golfers players. They're just terms so that the patients are more familiar with, rather than medical terms.
Brilliant. I think that's it. We're all wrapped up. That's fantastic. That's all the questions. Thank you guys for joining us. I'm going to stop sharing and we're going to stop recording this as well. If you have any questions, feel free to sort of connect with us on our social media channels. That's R&D Physio.